A little bit about the center. Our vision is that we want all aged care consumers to experience inclusive and accessible care. And our purpose is to build capacity and capabilities of the service providers, aged care service providers, to deliver services that are welcoming, inclusive, and accessible. And some of our service areas include inclusive practice training and workshops, such as this one, capacity building to promote cultural inclusion and equity, such as resources that we have on our website, and diversity advice and consulting, which we do on ongoing basis with the government bodies and as well individuals that work in the sector. There are over 420 languages that are spoken in Australia, including 183 Indigenous languages. There are top 5 languages that are used at home other than English, and they are Mandarin, Arabic, Vietnamese, Cantonese, and Punjabi. Around 37% of people over 65 years were born overseas, and the 2021 census collected information of more than 120 religions and faiths. And in the Department of Health and Aging data from 2020, around 28% of people who use home care and 20% of people using permanent residential and respite care were from CALD background. There is also a culturally diverse aged care force, and 21% of the total direct care workforce identify as being from a CALD background. And last, the personal care workers account for 91% of all CALD direct care workers. So that's quick info statistics for you. And then we will go into the bios for our wonderful presenters today. Mich Thornton will be presenting first. Mich is a lecturer in audiology at Charles Darwin University. Their interests include equity and diversity in hearing health, hearing rehabilitation, and clinical education. They are currently completing a PhD at the University of Queensland, investigating experience of hearing impairment and accessing hearing services among culturally and linguistically diverse adults in Australia. Mich also has many years' experience as a clinical educator, audiologist, and clinical program designer. So that's Mich. And our second presenter is Lourdes Zamanillo. Lourdes Zamanillo is Soundfair's Policy and Project Officer. She's a doctor in sociology from Monash University. She specializes in social inclusion, communication, and community building strategies. In her PhD, she used social network analysis to access the role of social networking sites as a tool for integration for recent migrants. At Soundfair, she is researching barriers and facilitators to hearing healthcare access for culturally and linguistically diverse communities. With more than 10 years' experience in the fields of communication and social change, Lourdes is very passionate about social equity, social capital, and fostering positive social change. So welcome, Lourdes and Mich, and we'll start off with Mich. So thank you again.
This is a topic that I'm very passionate about, so I'm so excited to be able to share some thoughts on it with you. So I want to talk to you today with sort of 3 different hats on that I wear, because I think that each of those perspectives gives a different idea about this particular topic. And this topic is what you would call a bit of a wicked problem, where you're taking, multiple different identities, multiple different issues that all intersect together, and sometimes it can be difficult, to work out what are the solutions, what's interacting. So I'm a clinical audiologist by profession. I've been doing that for about 18 years. I'm also a lecturer in audiology, and I currently lecture for Charles Darwin University. And I'm currently completing a PhD through the University of Queensland, and I'm researching hearing health inequalities in cold populations. So one of the first things we might want to know is how common is hearing loss in cold populations? And the key thing is that we don't actually really know for sure, which is really a bit surprising. We've had some overseas studies that suggest that hearing loss is highly more prevalent, and hearing aid uptake is less prevalent in particular cold groups. The problem is that this is overseas data, and we actually lack data in an Australian context. What we do know is that it's highly likely that hearing loss in elderly cold groups in Australia is very, very prevalent. And it's also likely that there are additional barriers to accessing help for hearing loss for these groups. But the other thing that we might ask ourselves is, well, why does this really matter? So if we're looking at an elderly population, why are we thinking about hearing loss so much? Obviously, there's a lot going on for elderly people. Why would we want to even prioritise hearing loss? The thing is that hearing loss, especially if it's untreated, has a very big impact on individuals, even though it's actually something that is often invisible. So untreated hearing loss can lead to depression, anxiety, loneliness. It can affect relationships. There's evidence to suggest that it leads to more frequent hospitalisations. It causes fatigue. It can lead to increased falls and frailty. There's an association with hearing loss and cognitive decline. It leads to more frequent communication breakdowns. People with hearing loss have particular difficulty in understanding accents, struggle to hear in background noise. They can have difficulty using the phone. And there are more. But that just gives you an idea of how impactful hearing loss can be for individual people. So how then does hearing loss intersect with both age and cold identity? Well, first of all, if we think about how hearing loss intersects with age, there can be age-related environmental changes that will affect people's ability to cope with a hearing loss. For instance, if someone were to move from a home environment to, say, residential care, they may have moved from being around more familiar speakers to less familiar speakers, in which case their hearing loss is likely to be a greater handicap for them. As I mentioned, there's often a lot of other priorities that go along with age, so there can be comorbidities which result in decreased prioritisation of hearing loss. So often it can go untreated. Elderly people with hearing loss often have difficulty managing the devices that could help with their hearing loss. They have a reliance on others, even just to seek help in the initial instance. And there's often the question by others, is it actually hearing loss or is it just cognitive decline? And sometimes, it's assumed that it's the cognitive decline and the hearing loss isn't looked at. We can also think about how hearing loss intersects with cold identity. So firstly, the handicap associated with hearing loss can actually vary between first and subsequent languages. So if someone is conversing in their first language, they may experience less of a hearing handicap than they do if they're conversing in subsequent languages. So it really matters who they're talking to, who's in their environment. Again, there can be increased reliance on others in the help-seeking phase. There can be, in particular cold groups, increased stigma and a lower prioritisation of hearing loss. It can be seen as, it's not necessarily seen as a health condition that's really important to treat. And there can be issues in terms of pathway accessibility. So in terms of knowing how to seek help and where to seek help. So then we have the intersection of hearing loss, age, and cold identity. Now, all of these things individually can actually lead to increased socialisation, but what we really need to be concerned about, and what we don't 100% know about yet is what is the compound effect of these. And, what we might expect is that might lead to even a greater risk of socialisation and all of the issues that would go along with that. So a lot of work is currently being done in this work, and it will take place over the next few years. So one of those is my own PhD on hearing health among culturally and linguistically diverse adults in Australia. So as part of my PhD, I have looked at the literature to look at what evidence is currently available in this area, and I think it's fair to say not a whole lot. I've also started to look at some data, which Lou will also talk about a little bit more as well, from some focus groups with Mandarin and Arabic-speaking people with hearing loss, and looking at the barriers that they might experience to hearing services. I am going to look at some quantitative data from the HILDA survey, which is the Household and Income and Labour Dynamics survey, to see if we can get some information on the prevalence of hearing loss in cold populations and what factors might be involved in both the prevalence of hearing loss and also the uptake of hearing aids or hearing rehabilitation. My supervisors for this project are Professor Piers Dawes and Associate Professor Nerina Scarinci from the University of Queensland, and also Dr. John Newell from Macquarie University, have also been awarded a large grant from the Medical Research Future Fund, and their project will look at improving access to the hearing services program for people with culturally and linguistically diverse backgrounds. And they're looking at that from both an adult and paediatric perspective. It's a large multi-site research project which will be co-designed with people from culturally and linguistically diverse backgrounds with hearing loss. And then they will co-design solutions to equitable access to the hearing services program, and it will result in a multi-site field trial. Soundfair is also doing a project in this area, and Lou is going to describe that in great detail for you following my presentation. So preliminary recommendations from my PhD, so from the scoping review and looking at some of the early data from focus groups, suggested that there's a need for greater access to interpreters, a need for culturally responsive hearing healthcare, a very, very large need for accurate and systematic data collection, and there needs to be easily understood information on the pathways to accessing hearing help. But I guess what I want to finish with is just a little bit of an overview. There's obviously a lot of work to be done in this area. Some of that will be policy-based, some of that is at the individual level. But what could be done right now to assist people from culturally and linguistically diverse backgrounds who have a hearing impairment? And I think the number one thing, particularly in elderly populations, is not to assume it's either age or a language barrier, but to remember that it could also be hearing loss. Even if there are cognitive issues, even if there are language barriers, it doesn't mean that hearing loss isn't making communication even more difficult, and that treating the hearing loss is still going to have an effect of making communication easier. Okay, so you should always consider in the over 65 population that there could be a hearing loss, because we know that in the decade from 65 to 75, 1 in 3 people have a hearing loss, and that becomes even more prevalent with greater age. So it's important to know where people can get help for their hearing and to be able to pass that information on. It's really important that family members and significant others are included. We know that that's particularly important for cold people with hearing loss. It's important when seeking help for hearing loss anyway, because if I put my audiologist hat on, I have someone that I'm, say, fitting with a hearing aid, I also want to give information to the people that person is going to be talking to. You know, who are the main people that they're communicating with? They need to know how to make communication easier for the person with a hearing loss. It's important to liaise with hearing health providers regarding how to assist with hearing devices. So that can be a really tricky one in residential settings where there's a lot going on. And as an audiologist visiting that setting, it's a pretty common thing to find hearing aids in a drawer or not being worn. So that can be a really good way of helping people as well, is just learning how to manage those devices, which can be tricky. And the final thing is learn how to create a listening friendly environment. Changing up the environment can really have a big impact on how easy communication is. And that can be as simple as making sure that you turn off any extraneous noise sources, that you're actually looking at the person that's trying to hear you. People do pick up a lot of visual cues that help them when they're trying to hear you. It helps to fill in the gaps. And also things like lighting, if your face is in shadow and a little bit harder to see, can also help to facilitate good communication. So those things, most of them actually help anyone with hearing loss, but where you have the effects of age and, you know, potentially language barriers, and again, accents are harder to hear, all of those things are going to be even more important in this particular population. So I'm going to hand over to Lou now, and I invite you to ask me any questions once we get to the Q&A section. Thank you.
Thank you so much, Mich. Hello, everyone. My name is Lou, and as Biliana kindly introduced me at the beginning, I'm a project policy and project officer at Soundfair, which is a not-for-profit working towards hearing equality across Australia. So firstly, thank you, Mich. You gave a wonderful presentation, and I think what your presentation really highlighted for me, and I'm sure for everyone in the room, is the importance of hearing conditions and the potential impact that they can have, especially in elderly populations. So adding on to that, my presentation focuses a bit more on, I like to see it as a case study, I guess. Like we're with this project, we're really trying to find the evidence, the empirical evidence, to find out what we can do about it. Like we know that the impacts are big, but what can we find out, and how can we change that for the better? So I'll start by giving you a bit of background into this project that we started earlier this year. In March of this year, we were contracted by the Federal Department of Health to conduct this piece of research. And the main idea is that we want to provide recommendations on how to improve hearing healthcare access and uptake of hearing healthcare services for people from cultural and linguistically diverse backgrounds in Australia. And the way we went about it is we essentially did a qualitative study where we used community participation to determine what are the current barriers and potential facilitators to uptake and access of hearing healthcare services for CALD people in Australia. And that involved everything from doing a literature review to find out what we already know about the topic, to then having, as Mich mentioned, focus groups with CALD community members. And the other thing that we did is we had several interviews with key stakeholders from hearing healthcare services, from community health services, as well as from multicultural peak bodies, to try to get the big picture and put the pieces of the puzzle together of what's happening with hearing health in Australia for CALD populations. So that's what we've been doing for the year. And as of end of August this year, we had completed 17 interviews with hearing health service providers and other key stakeholders, as well as 2 focus groups, one in Mandarin, one in Arabic. The reason why we chose these 2 languages is because, as Biljana mentioned at the beginning, they're the 2 most common languages after English spoken at home. And we also had an intersectoral workshop in October where we brought people from all of the sectors together to really discuss how can we make changes at a systemic level. And some of these people included people from the Federal Ethnic Communities Council of Australia, people from the Centre of Culture, Ethnicity and Health, the National Ethnic Disability Alliance. We also had people from education bodies such as the Australian College of Audiology or Audiology Australia and the Aged and Community Care Providers Association. And then hearing healthcare providers from Hearing Australia, Audica, and other bodies. So as you can tell, it was a very comprehensive project, and we got some really interesting findings out of it. These were some of the stakeholders that we had at that intersectoral workshop, which just happened. And the reason why we wanted to bring everyone together was to really see how we could work together, because ultimately this is not something that we can solve in silos, to improve uptake and access of hearing healthcare services in Australia. A bit of theoretical background for this study, just to frame the findings that I'm going to share with you in a second. In terms of a theoretical framework, we use the NHMRC's Cultural Competency Framework, which was created by the NHMRC in 2006. And it essentially states that there are 4 dimensions that really impact cultural competency, and both in barriers, the barriers that impact cultural competency of services, as well as how we make sure that it happens. The first dimension is the systemic dimension, which refers to any existing mechanisms for monitoring and fostering cultural competency. So an example of that would be nationwide policies and procedures, for example. This dimension is concerned with governance and regulation issues, and its elements mainly determine the clinical pathway for people accessing hearing healthcare services in Australia. So that would relate to what Mitch was saying about people finding it hard to navigate the pathway towards hearing health, for example. The next dimension would be the organizational dimension, which essentially refers to any skills and resources within organizations themselves. So in this case, hearing health providers, to ensure that their services are culturally competent. So this dimension is concerned with, again, policies, but at an organizational level, staffing, management practices, and its elements determine accessibility of services. So again, going back to what Mitch shared with us, for example, access to interpreters or having translated booking forms, for example. Next up would be the professional dimension, which refers to any educational components of healthcare providers' professional development. And this dimension is concerned with cultural competency standards and any mandatory training requirements, which one of the things that we found is that at the moment, there's no standardized cultural competency training in Australia, which is one of the barriers that we have for healthcare providers to feel competent enough and confident enough to provide culturally appropriate care with CALD communities. And finally, the individual dimension refers to the knowledge, attitudes, and behaviors of healthcare providers themselves on cultural diversity matters. And this also applies to any individual behaviors, attitudes, etc., from the CALD people's perspective, in the sense that, so if we're going to talk about cultural barriers such as stigma, for example, and the notion of hearing loss being associated with something negative in a person's culture, that would fall under the individual dimension of this framework. So with this in mind, we essentially started analyzing the data from the interviews and the focus groups and trying to understand and categorize where all these factors were playing, and to get that big picture as to what's happening with hearing health in Australia. So, what did we find? First and foremost, in this table, for example, I've coded the darker blue as the systemic barriers that we found in the stakeholder interviews. And then as we go lighter, the ones on the bottom are the individual ones. So in alignment with previous literature from other countries and from other health areas in Australia, at a systemic level, we found that new arrivals have really fragmented or no information about how to navigate the Australian healthcare system. So people come to Australia, and oftentimes they come from countries where they can, for example, see a specialist straight away. And they don't know that they need to go to a GP first to then get a referral to then see a hearing health specialist. So what then happens is that because the system is quite complex and they don't know how to navigate it, coupled with language barriers, it's really hard for them to access care. Another thing that often happens is that going to a cultural barrier, which would be at the bottom, but a lot of times and in a lot of cultures, there's the notion that hearing loss is just a normal part of life, or that it's not really a problem, or that you don't really have to do anything about something hearing health-wise until it really becomes a problem. So people wait until it really becomes a problem and it's impacting their daily life before they seek help. But because there's no knowledge of all the processes involved to get that help, then they're expecting to just be able to get help straight away. And when they're placed in waiting lists and figure out that they need to see several specialists before they get the help that they need, that really creates frustration. A lot of hearing loss goes undiagnosed, as Mich was saying, because coupled with language barriers, it often is dismissed as just a language barrier, when it's not necessarily the case. So one of the things that we're advocating for is having that diagnostic checklist when primary healthcare professionals or any kind of carer can really ask, do you have trouble hearing when someone comes in? Because oftentimes the person will have trouble hearing, but they won't think to raise it if they just think it's a normal part of life. So that sometimes goes undiagnosed for up to 10 years. Another systemic barrier was the fact that as it is, temporary migrants are not eligible for services, so for funded services. So at the moment, both the HSP and the NDIS are only available for permanent residents and Australian citizens, which means that asylum seekers, for example, cannot access these funded services. And again, as Mich mentioned, we don't currently have any standardized data collection mechanisms at a national level, which is highly problematic because even now, we know this from first accounts of people that face this every day, but we can't make any conclusions statistically speaking or quantitatively speaking because we don't have that data. And even if we start putting in interventions to improve things, we don't have a way to benchmark and then measure impact. At a service provision level, the main barrier that we came across in the interviews were language barriers, in the sense that interpreters are not funded. Free interpretation is not funded for audiologists and audiometrists. Now it is. In October 2022, now audiologists and audiometrists can access free interpreters. But before then, it was a problem because people that didn't speak English couldn't access services. But even if you do have an interpreter available, you need to look at booking forms. You need to look at when you call into a clinic to make an appointment. So those having translated information materials, for example, that people can take away and have a look at them. And in that sense, if you have an interpreted appointment, you also need to account for longer amounts of time for that appointment. And then at an individual level, we encountered issues such as stigma. So people fearing and not wanting to let other people know that they had a hearing loss because they were afraid of that they'd be judged or that they'd be ostracized. Not having family members to help them access services if they can't speak English and they have no one to take them to the appointments, it's highly problematic. Or if they have other comorbidities that prevent them from going there themselves. And competing life responsibilities, where a person needs to care for other people and work. Hearing loss is obviously going to take a back seat. And cost. In addition to this, in the focus groups, we also found, as I mentioned, that oftentimes there's no concept of preventative healthcare, and that there's a lack of understanding of what hearing aids do and don't do. And because of the short time frames of the appointments, oftentimes that information is not taken in or the expectations are not clear. So people think that the hearing aid is going to fix their hearing where it's not the case. So there needs to be more information on that. So as I mentioned, what we did essentially was take all this information and try to put it in the categories from the NHMRC to try to make sense of it. For the sake of time, I will save you from repeating myself with all that I've already shared. But what does this all mean ultimately? What can we do today and now? So the first thing that should be a priority is improving our data collection mechanisms. And what that means, for example, including cultural background in national surveys such as the SDAC, that also means at an organizational level, measure demographics, ask people what their cultural background is, because it does impact on the quality of care that we need to give. And we do need to accommodate for the needs of someone from a different cultural background, depending on that cultural background. Measure interpreter usage, for example. Measure continuity of care. Do people from CALD backgrounds not come back as often as people from non-CALD backgrounds? What's the client satisfaction level? Are they happy with the services they're receiving, or do they need something else that we're not currently providing? A good way to look at that as well is make sure staff reflects catchment area demographics. So if you're in an area that has a high index of people from an Asian background, consider having staff that are from an Asian background so that people can see themselves in the service that they're accessing, and ease those cultural barriers, because it's not only about language barriers. Ask people if they have trouble hearing, first and foremost, to make sure that we catch it before it becomes too late. The second thing, training. In that sense, one of the things that we're proposing as a ongoing project after we finish with this research is to create a standardized cultural competency training for all health professionals, so that we all have the tools to be able to provide culturally competent care. And in this sense, we want to be able to include the consequences of not attending a hearing health or to mental health and well-being, because the impact of hearing health, as Mich highlighted, is significant. And we need to know how to support the people that are facing it. And lastly, outreach and engagement. First and foremost, with appropriately trained interpreters as partners in service delivery. Second, using translated and culturally appropriate information materials. Thirdly, creating campaigns and resources for CALD communities that target friends and family, because they're ultimately the decision makers in most cases that will encourage the person to access hearing healthcare. And in that sense, we really want to work together with CALD communities themselves to find champions and amplify their voices and make sure that the materials that are designed are being co-designed, and we're not just saying what we think they should know, but that probably will not resonate. And using CALD channels for distribution in that sense, like really, really working together with CALD communities to make sure that we're answering their needs. So that's essentially where we're at. As I mentioned, we're finishing this project in December. We're handing in our recommendations in early January. So if you have any lived experience or comments, I'd be delighted to hear them. And then the next stages are going to be finding ways in which we can action the recommendations that I've just shared with you. But feel free to send me an email if you want to stay in touch or become involved with this project. There's much to do. That's it. Thank you very much.
I will start with the first question that was asked by Sula. In terms of the numbers of prevalence of hearing loss across the Australian population, 65 plus, 75 plus, and 85 plus, what do we know about numbers, statistics in that segment?
I haven't got those figures off the top of my head in those particular age categories for the Australian population. I think there is some data on that. In general, from a US study, we know it's 1 in 3 for 65 to 75-year-olds. And in the general Australian population, it's 1 in 5. But I'd have to do some looking up to find the exact figures for those exact demographics.
Oh, great. Thanks, Mich. And we maybe add that into the presentation as well. Now, there was another question I had that was around creating a listening-friendly environment. And I just wanted to ask, in terms of what's important, obviously, for the multicultural community is the interaction with the interpreter. So, is there anything that service providers need to specifically take into consideration when working, with interpreters? And Lou, you mentioned the training as well. So anything else that you could maybe share with the audience? Because I'm sure we have a lot of service providers in the room. What's important to create an appropriate environment there?
The two things that come to mind is, firstly, consider adding more amounts of time, like having longer appointments, so that, because ultimately, like, the information is always going to be shared twice, like when you say it and then when the interpreter says it. So you need double the amount of time to share the same amount of information. Secondly, and very importantly, always address the person you're speaking to, not the interpreter. We have to keep in mind that we're providing service to the client, even if the communication is being led through a third party. But ultimately, the relationship building is with the CALD people themselves, not with the interpreter. So you can hear the interpreter, but keep speaking, making sure that you keep eye contact with the persons themselves. Those are the two biggest things that come to mind when engaging with an interpreter. The third thing would be make sure you're not using a lot of jargon, because oftentimes that's where things get lost in translation. So try to simplify the terms as much as possible to make sure, and that's just like general good practice, but to make sure that the terms that there's no miscommunication in that sense and that it's easily understandable.
Mich, you mentioned that the information needs to be easily understood to make sure that people can actually access hearing help. So it goes a bit to community engagement as well and project delivery, but any sort of insights that you can share, or any recommendations that you have learned from that's useful in that sort of engagement?
Well, again, not using jargon in information about pathways is very useful. The Hearing Services Program does have some information that is translated into some languages. So I would suggest that the Hearing Services Program website is a nice place for people to start if they're not sure where to go.
In terms of simplifying information, another big thing is health literacy. In that sense, and this is not even for CALD populations, but populations in general. One of the things that we learned from the workshop was that there was a recent study with GPs, for example, and they found that, like in primary healthcare, 97% of people surveyed felt that they felt confident in what they knew about health and how to navigate health services in Australia. When they actually tested it, only 41% were. So health literacy is quite lower than people think it is. And then literacy levels in general, when considering CALD populations, we can never assume that people know how to read or that they will know certain terminologies. So sometimes written materials are not the best way to go. So we think, we'll just translate it, but that doesn't necessarily mean that it's accessible. So having different formats of information materials, such as video or graphic materials, is another way to make sure that the information gets across.
There is a question from Elham, and she mentioned the current code of conduct for audiologists does not require engagement with interpreters. How can this be updated to ensure safe quality care is provided? And also wanted to mention, she mentioned before that some local government areas fund access to interpreting services for people with hearing impairments. So any sort of comments on Elham's question?
We're currently working with Audiology Australia and with the Australian College of Audiologists to try to make some changes. But I think that's ultimately advocacy at this point. I don't know if you have any further comments from within the industry, Mich.
Yeah, well, I think, the fact that interpreters will now be funded for audiologists is going to create quite a change there. And so in terms of the code of conduct, I don't know what plans are there, but I suspect the fact that interpreters will now be funded is going to change that space a bit.
Question from Dunya, and that's, are there ways in which we could encourage our patients to participate in any relevant research?
Regretfully, right now for the current project where we finished the data collection phase a couple of months ago. However, that being said, please send me an email because we do want to continue with this project. So I know we want to test several ideas and co-design the materials, for example, with CALD community members. So it would always be lovely. Like, I'm sure there will be more opportunities in the near future for engagement. So send me an email and we can tee something up, essentially. And Mich, with your PhD.
Yeah, so I'll have another recruitment phase next year. And also the large research project, the MRFF project, will probably be recruiting next year as well, I would say. So there's certainly a lot of opportunities. How to encourage people to participate, that's typically been something that's tricky, getting recruitment for CALD participants, and is one of the issues and one of the reasons that we lack data as well, is actually, making sure that recruitment is done in a culturally responsive way as well?
I think in that sense, we found like we did get very different responses depending on what call communities we were approaching. So in that sense, what we made sure is to have translated recruitment materials available. But we did find stigma in Arabic speaking communities, for example, is way bigger than for the Mandarin speaking community. So there was a lot of reticence from Arabic speaking communities to step up because they didn't want other people to know that they had hearing loss. So in that sense, one of the things that we want to trial out is having increasing representation to destigmatize hearing conditions. So trying to find spokespeople from the call communities that we're looking at to help with recruitment and to share the message, and hopefully that will encourage people to step up.
Elham, you were saying that it's at the moment in your local government area in New South Wales, it's possible for audiologists to access interpreting service. Is that a pilot project, or is there anything else that you wanted to share with us? It's because it's useful for people to know, I think.
Yes, hi. It is a pilot project, but it's nationwide. So it's across all states. If you go to the TIS website, it actually identifies, for example, in Queensland, it's Brisbane, Townsville, Cairns. So they've selected areas where they have a higher CALD population.
Thank you, Ellen. I really appreciate all the great questions and great answers. It was really nice to have that engagement with the whole group. And now we go to where we go for support at the Center for Cultural Diversity and Aging, how we can support you. We have pretty much, the whole year, whole financial year covered with different topics. And the next one in February is going to be food for thought, the link between food, culture, and identity. We always find this is a very, popular topic, and, the importance of culturally appropriate food for people, especially in residential aged care facilities. Then in March, we're going to launch our movie, which we had with Senior Citizens Club leaders, their visions for a more inclusive aged care system. That's part of the Harmony Week. And then you see there's other things coming up like culturally diverse perspectives on mental health care, multi-phase initiatives in aged care. And the last one in June is a face-to-face event. It's a cultural awareness walk with Uncle Shane Charles about the hidden cultures of Melbourne and decolonizing Melbourne. Now, I also want to mention our diversity mentoring program. We have a great program that Lisa Tribuzio and Georg Tam established here at the Center for Cultural Diversity and Aging, which is a diversity mentoring program. And it's really tailored advice for aged care organizations, especially, resi care and home care, to improve their way, how they want to engage with older clients, whether it's developing a diversity strategy, whether it's, having a self-assessment. So we actually have a tailored program where organizations from a catalog of different options can go through the mentoring program and participate and make the organization more inclusive. It's really across the organization. That's our intention. And so we still have free spots, not many, but we still have free spots. If you are interested, have a look at our website on Diversity Mentoring Program. You can apply for it. Obviously, there needs to be a commitment from the organization, that you really want to work on that, and that, across the organization, you're willing to advance your diversity, equity, and inclusion agenda. Have a survey on our website. So we're always looking for, getting your feedback from the sector, from experts, from the community, how we can improve the aged care system for called seniors. So we've already received a few responses. So if there's anything that you want to share with us, please consider filling in the survey or just email us at info@culturaldiversity.com.au. And obviously we have a number of resources, including our practice guides and the Everybody Has a Story free learning module. This is something that we work very closely with the Aged Care Quality and Safety Commission. And you can access that training, Delivering Culture Inclusive Care, at our website under Training and Development. And obviously we know the standards they might change, but we know that culture, inclusion and diversity still is going to continue to be a very important topic, with diverse groups increasing in numbers and more awareness as well. Now we have a great podcast, One Size Doesn't Fit All, that Biljana has developed and has interviewed amazing leaders from the multicultural and culturally appropriate aged care sector. And we're very proud of the work that the center has done. So amazing work there, Biljana, obviously. And you can access the podcast through our website or Spotify, Google and Apple as well. So have a look, have a listen, I should say, to these podcasts. And the practice guides that we have developed on different topics. The newest one we have is on culturally appropriate dementia care. I think this is a very pertinent one, giving, the Commonwealth is consulting on dementia at the moment quite specifically and quite focused. So there's other ones, 10 steps developing diversity, equity, and inclusion plan in aged care, spiritual support, access and interpreters, what we discussed now, culturally inclusive feedback, communication. So there's sort of 2 pages, generally 2 pages, gives you sort of a high level overview on that specific topic, what you as an aged care provider may want to consider when working with diverse audiences, clients called seniors. And also, if you want to promote the work that we do or want to sort of share it with your staff, we have a poster that you can put in your facility, and that sort of highlights the work that we do. And it's sort of quick way to build a bridge between us and your organization. Another project we always would like, always want to highlight it's really important, is the connecting older Australians to aged care service, better connecting with diverse audience, or we sort of internally sometimes call it free translations and aged care project, because at the moment you can actually get your resources, if you're an aged care organization, translated. Email diversityagedcare@icanagency.com.au or go to their website. If you just Google connecting older Australians to aged care services, better connecting with diverse audience, where you will find the website of the government, and you can pretty much translate anything that you need, except if it's marketing material, then it's a little bit different. But any sort of information that's relevant for your seniors, it's home care agreements or, how to access, information, you can use that. We are part of the Partners in Culturally Appropriate Care program. So there's a PCAC organization, each state and territory. We are the one for Victoria. So please feel free to reach out to your local PCAC as well if you need any support in working with cold seniors or, looking into diversity more broadly.
You can find us at culturaldiversity.com.au. Please follow us on LinkedIn, and we share great content there. And also Facebook, where we also share our webinars and other good practice stories and news from the sector. And thanks you for today, and goodbye.